topic of today's presentation is the echocardiographic assessment of TR, mechanism quantification, and device selection. We have a lot of ground to cover, so I'm going to dive straight in. But before we go into the assessment of TR, just want to quickly highlight some important anatomical landmarks which are very useful in assessing TR and also during procedures. So the first is the aortic valve, which is at the superior anterior part of the heart and is very close to the septal and anterior leaflets. So whenever the aortic valve is in view, you know the septal and anterior leaflets are not far behind. Opposite to the aortic valve, you have the coronary sinus, which is at the inferior posterior part and is very close to the septal posteral commissure, again an important anatomical landmark. And then finally, you have the anterior papillary muscle, which is the largest and most consistent papillary muscle of the tricuspid valve, and this demarcates the division between the anterior and posterior leaflets. So we can then apply that anatomical knowledge to our standard echocardiographic views. First of all, transthoracic, and first view we typically obtain is the RV inflow view, which is obtained by tilting away from the aortic valve in the peristernal long axis view. So when you then encounter the coronary sinus, you know that you will transect the septal leaflet with typically the anterior leaflet. The more you move away from the aortic valve, the more you tilt away, and the coronary sinus disappears, you will then transect the anterior and posterior leaflets. If you then turn your probe 90 degrees, you get the short axis view. There it's really dependent on the elevation. If you point up high, you're typically going to see the anterior leaflet. The more you move down, you're going to see the posterior and also septal leaflets coming in. The same holds true for chamber view. When you tilt up towards the aortic valve, typically 5-chamber view, you will have the septal and anterior leaflets in view. If you conversely point down towards the coronary sinus, you will see the septal and posterior. Anywhere in between, the lateral leaflet can be either the anterior or posterior. Then it really depends on the rotation of your probe, but also on the anatomy of the tricuspid valve. In addition to transthoracic, we often also use TEE for imaging the tricuspid valve, assessing TR mechanism and quantification. I would say there are three important levels at which we can image the tricuspid valve. The first being the mid-esophageal view, which would be the standard view, which is a very good view to get a good overview of tricuspid valve. We can interrogate it from different angles, rotating all the way from 0 to 180 degrees. The main downside, however, of this view is that the tricuspid valve, as you can see, is quite far from the probe, meaning that the lateral resolution will be less. And secondly, there's also a lot of tissue in between, and especially when there is a prosthetic valve, prosthetic aortic or mitral valve, there can be a lot of shadowing or attenuation of the septal and anterior part of the tricuspid valve. And so therefore, I think it's always nice or always better also to try to have a deep esophageal view just by pushing in the probe, and sometimes also using the small wheel to move towards the right side of the patient, and so that you can get an unobstructed view of the tricuspid valve through the right atrium, with an added bonus that the tricuspid valve is now much closer to the probe, meaning you will have a much better lateral resolution, and therefore this view is actually way better typically way better. It's not always easy to obtain, but if you have it, it's a better view, for instance, to do 3D reconstructions and NPR, for instance. Final important TE view is the transgastric view, transgastric short axis view, which gives you a really great overview of the tricuspid valve morphology, and you can also call it like a poor man's 3D, because it will give you a view similar to an on-fast view of a 3D, and this can be particularly useful when 3D itself is of insufficient quality due to leaflet dropout or attenuation. So as I mentioned, this view is also very useful to look at tricuspid valve anatomy, and this is important because, in contrary to what its name suggests, research has shown that the tricuspid valve is actually only has the typical tri-leaflet configuration about half of the patient. Other patients will have a more complex tricuspid, for instance, a quadricuspid valve, as shown on the right. This is actually a very nice study by Becky Hahn, in which she evaluated the morphology of 570 patients. As you can see, only about 54% had a classic type 1 or tri-leaflet configuration. About 5% actually had a bicuspid tricuspid valve, typically with a fusion of the anterior and posterior leaflets. And then about 40% had a quadricuspid valve with two posterior leaflets, P1 and P2, or the type 3B being the most prominent subtype. And then finally, there's also a very small minority of patients who even have more complex anatomies. This is called type 4. Now, whether this is truly a different anatomy, meaning that there are more than 3 different leaflets, is still a matter of debate. But it's safe to say that the more complex the anatomy of the valve, the morphology of the valve looks on echo, the more complex typically also the regurgitant orifice will be, and also more complex the subvalvular apparatuses, which will all influence, for instance, transcatheter procedures, especially transcatheter edge-to-edge repair. Very important when assessing TR is also to look at the mechanism, what is causing the tricuspid regurgitation. A very useful view in that respect is the X-plane view, which gives you or 2 orthogonal views, with on the left the commissural, or the also sometimes called the RV inflow-outflow view, which is typically obtained in the 60 to 90 degrees configuration. And this gives you the posterior to anterior direction of the valve, anterior being close to the aorta. And then 90 degrees off that, or sometimes a little bit less, depending on the patient, you have the long axis view with the septal to lateral orientation. And so when we then pan across the valve, we can really interrogate every specific area of the valve. So when you stay close to the aorta, you know you're going to see the anterior and septal leaflets in the long axis view. If you then move more posterior at a certain time point, you will encounter the large anterior papillary muscle, and this will delineate the border between the anterior and posterior sections of the valve. So if you then move more away from the aortic valve, you're then imaging the posterior and the septal leaflets. Similar and also very important view in that respect is the T multiplanar reconstruction, which is a reconstruction out of a 3D volume. This can be done offline, but also typically online during procedures. And this gives you, typically we have 4 different views. On top you have the commissural view and the long axis view, akin to the T X-plane, but it gives you 2 more very nice additional images. On one hand, you have an axial slice, which is typically obtained through the valve, and this gives you sort of a short axis view, like the transgastric view. Then finally, you have the 3D rendering, which can be oriented in 2 different ways. The first way is to put the aortic valve at 10 or 11 to create a so-called surgeon's view, or a 3D on fast view. However, during procedures, we typically like to put it on at 5 o'clock, so that it kind of mimics the transgastric view, and that way there's minimal confusion for the interventionalist when he looks at the different images at the same time. Then what are the different types of TR? Well, recently there was an updated classification, and there are actually 3 broad categories. First being primary, meaning that the pathology is situated in the leaflet. You then have also secondary, in which the leaflets themselves are okay, but the valve is leaking because of changes in the surrounding structures. And then finally, there's the lead-induced or lead-related TR, and this is obviously unique for the tricuspid valve, because it's typically the only valve on which basic leads are placed through. So how do we then distinguish these different types? Well, as mentioned, primary TR is dominated by pathology in the leaflets itself. This can be excessive motion of the leaflets, prolapse, flail, but can also be very restricted motion, for instance, due to carcinoid or rheumatic heart disease or radiation. Or it can even be destruction of the leaflet, for instance, perforation in the case of endocarditis. Then secondary, there are 2 subtypes actually. You have, on the one hand, the ventricular secondary TR, in which the primary problem is situated in the ventricle. This is typically accompanied by RV dilation and also dysfunction, which then causes an apical and lateral displacement of the papillary muscles, which causes tethering on the leaflets and apical tenting of the tricuspid valve leaflets. On contrary, in atrial functional TR, as the name suggests, the pathology is situated in the atrium, typically associated with atrial dilatation, annular dilatation, which then pulls the leaflet apart and from the outside, so that they actually become more flattened, and then coapt at the annular level, and eventually, when the dilation continues, there is a central occurrence of a central coaptation gap. And then finally, lead-induced. There, it's really important to have a clear interaction with the lead, between the lead and either the tricuspid valve leaflet, or the subvalvular apparatus. So the presence of a lead is not sufficient to diagnose lead-induced. It has to be really interacting with parts of the valve before this diagnosis can be made. So it's not only important from I would say, a diagnostic standpoint to make a difference between, for instance, the different types of atrial, functional TR, atrial versus ventricular, but it also impacts patient prognosis, because we know that ventricular FTR actually carries worse prognosis than atrial functional TR. And within ventricular functional TR, there's also a further distinction with patients who have pulmonary hypertension having worse survival compared, for instance, to patients with isolated RV dysfunction. Coming back to lead-related TR, it's important also to report where the lead is particularly situated. We can use the different views, as mentioned at the beginning of the presentation, to really orient ourselves around the valve and then determine where the lead is situated. But in most cases, the lead will either be in the center of the valve or towards the posturoseptal end of the valve, just because of the way the lead is implanted from the SVC and then lies in the curve into the septum or the apex of the RV. It makes it that the lead is typically in this area of the valve, but it's important to look where it is particularly situated, because this will obviously impact, for instance, repairability of the valve with transcatheter systems. As mentioned before, before diagnosing lead-related TR, you need to be absolutely sure that there is an interaction, because not always the lead is causing TR when it is present. Because about 7 to 30% of patients with the lead have been shown to have at least moderate TR, but this does not mean that the lead is the causative mechanism. There really has to be an interaction between the lead and the leaflet or the subvalvular apparatus. And this is important not only because we know that lead-induced or lead-related TR obviously worsens TR, but also because it also impacts prognosis of patients who develop lead-related TR will do worse over time compared to those who have a lead and have incidental TR or TR due to other reasons. Another important question is about tricuspid regurgitation, is particularly severe TR, is if all severe TR is created equal. And with that I mean, is a patient with an EROA of 0.5 versus an EROA of 1, do they have the same prognosis, because they would all fall within the same category as severe, or is there a difference? Does the prognosis continue to decline with worsening TR? And so this has actually been on the mind for interventional cardiologists for quite a while, because often when we do transcatheter procedures, we are able to significantly reduce TR, but typically not completely abolish it, in contrast, for instance, to surgical replacement or repair. And so this has kind of been a conundrum for interventionalists, because we've seen that we've significantly reduced TR. Patients also felt better, had better functional outcome, but despite the fact that if you would grade their TR, would still within, for instance, be in the severe range. And so this has inspired Becky Hahn to actually propose a more graded, a 5-tier grading system for TR, better stratifying our severe TR patients, subdividing severe into 3 categories: severe, massive, and torrential, with increasing severity. Now, this obviously begs the question. It's nice to separate these patients, but is this really supported by evidence, hard evidence? And so this is an interesting question that was addressed by this study by Perry et al. About 3 years ago, in which this is a group of 180 patients with severe functional tricuspid regurgitation, and they used the group mean survival as the reference point. And as you can see, with increasing TR severity overall, there appears to be indeed an increase in adverse events. However, initially there is some sort of a plateau phase, suggesting that initially survival would remain quite similar. And if you look at the confidence intervals, which are obviously broadened at the outliers, actually it's only at very high EROAs of around 0.8 that on multivariate analysis, survival becomes statistically significantly worse in this group, meaning that it's only statistical significant difference between torrential TR and severe TR patients, but not really within the severe and massive categories. This was appeared to be confirmed by another study by Fortuny, which is a Dutch group, about 1,200 FTR patients, showing again that if you separate severe TR patients based on the vena contracta, that there is actually not a big difference between severe, massive, and torrential. There is a continuum, but it's not statistically significant. However, and moreover, if you then look at EROA, actually only patients with an EROA over 80 had a statistically significant worse prognosis than those with a moderate, severe, or massive TR. So again, confirming that there might be a difference between the torrential and the other groups, but that within the severe range, the severe and massive might not be that different at all. Another important question when addressing tricuspid regurgitation is the question to when to diagnose severe TR, because we know that, for instance, the EROA, a cutoff of 0.4 is proposed, but this is actually an extrapolation from studies done on the mitral side. So it might be that on the tricuspid side we need to use a different cutoff, and this is from the same study as shown before by Perry et al. But now they used 700 patients with all-cause TR, mild all the way up until torrential. And again, they show you the survival curves with the group mean as a reference. And as you can see, there is an increase in adverse events with increasing TR severity. But again, when you look at the confidence intervals, it's actually at a EROA of around 0.35. So a little bit lower from the mitral side, that the statistical significance starts to emerge between these patients and the group mean. And this is more or less similar than that was discovered in a study by Denise Muraru et al. They looked at different parameters of quantification of TR severity, again noting a increase in adverse events with increasing TR severity, irrespective of the measure used. But if you then looked at tertiles of risk based on these three measurements, so the low risk, intermediate risk, and high risk. If you look at EROA in this study, a cutoff of 0.3 was actually associated with the 33% patients that had the worst outcome, again suggesting that a lower cutoff might be more appropriate for TR compared to MR. And then Fortuny et al. Also proposed a different way of trying to stratify our patients, not using the severe, massive, and torrential, but just first of all grade our TR based on vena contracta. If it's more than 7, diagnose severe secondary TR, and then use EROA to then sub-stratify our patients with severe TR into those with just severe and then also torrential STR, and then you have a more statistically significant separation of your three groups, and I would also argue a more easy and clinically useful way of subdividing our patients, and then maybe also use that for intervention. Now, I've spoken to you about the mechanism and the grading of TR, but obviously the most important question as echocardiographers is how do we then evaluate, or how do we determine how severe TR actually is? And for this, the guidelines recommend a multiparametric approach, integrating different elements. So first of all, structural evaluation of the valve, obviously looking at coaptation gap, flail gap, tenting height, and it's logical that the greater the coaptation gap or the tenting height, the higher the likelihood that you will have severe TR. If we then look at also look at RV remodeling, RV dimensions, RV annular dimensions, and septal flattening, because we all know that severe TR is associated, especially if it's long term, with volume overload, and this will obviously impact your right ventricle and cause dilatation and septal flattening. Then the structural evaluations then added up on qualitative Doppler assessments. First of all, the color flow jet area, which is actually mainly determined by jet momentum. The main advantage is that it's very easy to measure, but there are also important downsides in that it's mainly also influenced by machine settings such as your gain, but also by driving pressure and jet direction, because there's typically a lot of entrainment of blood within the right atrium from a jet, so the jet will appear larger than the actual regurgitated volume. This is particularly the case for central jets because they are obviously less constrained, so there is an overestimation of central and an underestimation of eccentric jets when using jet area as your main determinant of TR severity. It also leads to overestimation if the jet is not hollow systolic, as the guidelines recommend to use the frame with the greatest area as a reference point. Similar to the area, you could also use the Doppler continuous wave jet and look at density, duration, and morphology of the jet. Again, this is a very simple measure. Um, but again, it has certain limitations, such as central jets will appear denser than eccentric jets, and also within the spectrum from moderate to severe, it becomes really hard to make a distinction because the naked eye can't really distinguish the severe TR from moderate TR if a certain level of saturation is obtained. In addition to the qualitative Doppler, you also have semi-quantitative assessment, vena contracta being the most commonly used. The recommendation is to use an average of 2 vena contractas and 2 orthogonal sides, and this is because the tricuspid regurgitation orifice is typically non-circular, meaning that there's a high variability of the vena contracta based on the imaging plane you're using. The main benefit is that it's more independent of flow rate and driving pressure, and also less dependent on the technical factors, in contrast to, for instance, jet area. But it's highly variable, and also there's a lot of underestimation when there are multiple jets. To overcome some of these limitations, some have proposed to use a 3D vena contracta area instead of a single linear measurement. This has a benefit that it's more independent of orifice anatomy because you're using area, and you could also use it when there are multiple jets by just adding different areas. The main downside is that it's sometimes underestimates dynamic jets, and that it's not always easy to obtain. It's time consuming, and image quality is not always sufficient to have a reliable estimation of the vena contracta area. Another semi-quantitative measure is obviously hepatic vein flow. We all know that severe TR is associated with systolic flow reversal in the hepatic veins. The most important thing to note here is that it not only depends on TR severity, but also on compliance of the right atrium. That is not reliable in patients with arrhythmia such as AFib, or when there is a paced rhythm with retrograde atrial contraction, because then atrial contraction against the closed valve may mimic the systolic reversal by TR. But then, obviously, the holy grail of imaging of regurgitant lesions is to do quantitative assessment, because this will give you a continuous evaluation of severity. And the method that is most commonly used is the PISA or flow convergence method. It's based on the conservation of mass principle, and it assumes that when a blood is approaching the orifice, it behaves as a stack of hemispheric isovelocity shells with increasing velocity and decreasing surface. It depends on 4 essential measurements: the Pisa radius, the aliasing velocity, peak velocity of the regurgitant jet, and then also the velocity time integral. It obviously leads to a rapid assessment, both quantitative of lesion severity, so meaning the EROA, the regurgitant orifice, but also the amount of volume overload, so the regurgitant volume. And it's been shown to correlate really well with outcomes, as I've shown you also before. But the main downside is that it's a combination of multiple measurements, and therefore there's a compounding of error. Secondly, the PISA assumptions actually are more often than not violated in the case of TR, and so this will greatly impact accuracy. It's also less accurate in eccentric jets, or when the orifice deviates from the from the planar circular orifice. And because PISA radius is squared in the formula, any small measurement error in this will lead to a much more substantial error in regurgitant orifice severity. So we all know how to perform a PISA measurement, so I'm not going to spend too much time on that. Just important to say that it's advised to use a zoomed view, and I also like to have a color compare or a toggle color off to have an anatomic reference when I try to make my PISA measurements. But more importantly for us as echocardiographists and sonographers is also to know that the PISA method has significant pitfalls in the context of TR. The first one being the Doppler angular effect, and this actually goes back to the fact that the color Doppler will only show the velocity component of blood particles moving in the direction of the echo-insonation beam. So when the blood is approaching from the side, obviously the vertical component of this velocity will be less than the horizontal component. So this will cause the Doppler PISA to be smaller than the semicircular theoretically theoretical true PISA, and the PISA becomes more ergonoid instead of hemispheric. Secondly, because the orifice is non-circular, the PISA is also typically not hemispheric, but more hemi-ellipsoid, meaning there will be differences in the radius depending on how you transect the PISA shell. Thirdly, there is a temporal variability, obviously in TR, which depending on where you measure PISA can influence the evaluation of severity. So it's advised to use the PISA at a time of peak velocity in your Doppler signal. And then two things that are particularly also relevant for the tricuspid valve is, first of all, the principle of contour flattening, which is actually just means that the PISA shell, the shape of the PISA shell is actually dependent on the distance or the radius, the distance from the orifice or the radius, and secondly also of the orifice size, meaning that the more closer you get towards the orifice, the more flat the PISA will become. And the more away you are, the more parabolic actually the PISA is. And this is more relevant for the tricuspid valve because it has been shown that the underestimation of flow as a consequence of this is actually proportional to the ratio between the aliasing velocity and the maximal velocity. And so because maximal velocities are lower on the tricuspid side because of the lower driving pressures, the underestimation is more significant for TR than, for instance, for MR. And then the final important limitation is the fact that there is that the orifice is typically non-planar in violation of the PISA assumptions, and this will also impact the PISA shell and therefore evaluation of the PISA severity. And so to overcome these two limitations is actually a flow and angle corrected PISA formula that has been proposed as a way of getting a more reliable evaluation of TR severity with PISA. And this has been shown nicely in this recent study by Tomaselli with a group of Luigi Bedano in Italy, where they compared EROA and rigor and volume evaluation by PISA to what they call the gold standard being volumetric assessment from 3D echo. And as you can see, if you compare the gold standard, in this case volumetric, with PISA, that PISA actually underestimates TR severity by 0.15 on average for the EROA and about 10 milliliters for the regurgitated volume. But moreover, there's also a proportionality with TR severity, meaning that the more severe TR is, the greater the underestimation with the PISA method compared to the volumetric method. And so when you then apply this corrected PISA formula, you see that the error becomes smaller. The difference in EROA is only 0.05, and the regurgitant volume around 3. But more importantly, that this correlation with TR severity also more or less disappears, suggesting that this is a better way or more consistent way of calculating TR severity than the typical or classic PISA formula. And this also impacts, obviously, evaluation of TR severity, because as they have shown, there's an important amount of patients who are reclassified if you use the corrected PISA from mild to moderate, from moderate to severe, or even within the severe category, which then obviously might influence treatment decisions and therefore also impact patient prognosis. Then another quantitative method is the Doppler method, in which you compare the stroke volume to the regurgitant valve with a reference stroke volume from with a valve without regurgitation. In theory, this should be the optimal approach, but the main problem is that it combines multiple measurements, each with a large measurement error, and therefore the eventual result might not be reliable. And actually, this method is actively advised against in the most recent EACVI consensus document on multimodality imaging for tricuspid regurgitation. And finally, as I mentioned before, the volumetric method, in which you quantify or first calculate total RV stroke volume from end-diastolic and end-systolic volumes based on 3D echo, CT, or MRI, and then also quantify true forward stroke volume either through LV stroke volume, again from 3D echo or CMR, or use a Doppler or a CMR phase contrast method. So when you then integrate all these different parameters, you get a really nice overview of like in this table, and then this will allow you to have a more nuanced evaluation of TR severity, which is less prone to errors, because as I mentioned, all of these individual measurement or parameters are prone to errors. But if you then combine them in like an integrated approach, I think you're less likely to fall into the trap and really be able to diagnose your TR severity with more confidence. Then finally, it's also important to look at RV function when assessing TR severity. We can use traditional measures such as TAPSE, fractional area change, or S prime. But this is actually really relevant. This is a nice study by the Dutch group from Leiden, in which they subdivided their patients with severe TR into 4 groups. You had one group with normal RV size and function, second group with RV dilation but normal function, a third group with normal size but abnormal function, and then a fourth group with both abnormal function and dilated RV. And as you can see, if you look at prognosis, actually these are the 2 groups with RV dysfunction which have the worst prognosis, and this is irrespective of the fact or if the RV is dilated or not, suggesting that RV function rather than RV dilation is actually the most important parameter to look at. Then in addition to classic parameters for RV function, you can also use more advanced measurements such as deformation imaging or 3D echo. And this again gives you some additional information. Not only there's a lower RV strain, or I have to say less negative RV strain, it gives you worse prognosis. But if you look at the RV function assessment by these different parameters, you will see that if you use RV strain, a larger proportion of your patients will actually be qualified as RV dysfunction, suggesting that this might be a more sensitive marker of RV dysfunction. And then if you then look at prognosis, actually RV strain was the only imaging parameter of RV function which really added additional prognostic information to a baseline prediction model, and it even was significant on top of RV TAPSE and or fractional error change, suggesting that it really captures some unique information not captured by these traditional RV function measures. And then finally, for RV function assessment, there's a really a hot interest now into the RV-PA coupling principle, which just recognizes the fact that RV pump function in the end is a resultant of, on one hand, RV contractile force, and on the other hand, load, which is determined by 2 factors, pulmonary vascular factors and left heart factors. The invasive gold standard for RV-PA coupling or ventricular arterial coupling in general is obtained by pressure volume loop analysis and the ratio of end-systolic elastance versus effective arterial elastance. But obviously this is an invasive measure, not easy to obtain, a lot of pitfalls also, and some technical limitations. So therefore there's a real push to look for non-invasive estimates of RV-PA coupling. This can be obtained just by combining a measure of RV function with a measure of RV afterload. And in this respect, TAPSE is most commonly used as a measure of RV function, and PASP as a measure of RV afterload. And this has been shown to be predictive of survival, particularly after, for instance, tricuspid valve, transcatheter tricuspid valve interventions, with those who having RV-PA uncoupling, having a worse prognosis than those in which RV-PA coupling was preserved. And finally, if you look at the TR device landscape and echocardiographic assessment with respect to that, we all know that in recent years there has been an explosion in devices available for the tricuspid valve. There's a wide range of options now for patients, going from tricuspid valve repair, typically more commonly edge-to-edge repair, using TriClip or Pascal system. There are also transcatheter annuloplasty systems, although these have been used less in recent years. On the other side, you also have tricuspid valve replacements, which can be orthotopic, meaning that the valve itself is replaced, but can also be heterotopic, in which the valves are implanted not at the level of the tricuspid valve, but typically in the caval veins, with the intent of reducing the systemic congestion, which arises as a consequence of severe TR. Now, with respect to imaging and device selection, we know that there are a number of parameters that have been shown to predict procedural outcome in patients undergoing these procedures. particularly with respect to edge-to-edge repair. For instance, we know that an anteroseptal jet or anteroseptal pathology is more suitable for edge-to-edge repair than, for instance, a posteroseptal, and anteroposterior are actually unfavorable for edge-to-edge repair. In addition, the coaptation gap is very important. The wider the coaptation gap, obviously, the less likely we would be able to mate both leaflet edges. And finally, also the tricuspid morphology, as mentioned before, is important. And the more complex the tricuspid valve morphology, the less attractive it becomes for edge-to-edge repair. If you then look at the different categories or different categories of transcatheter tricuspid valve intervention, and which anatomy is then favorable, feasible, or unfavorable for each of these interventions, see that for edge-to-edge repair, the most ideal patient is a patient with a small gap, typically an anteroseptal jet, can be confined prolapse or flail, but not like excessive, and should be the classic tri-leaflet or bi-leaflet morphology. On the other side, when there's a very large coaptation gap, when there's a severe thickening, restriction, or shortening of the leaflet, when there are dense chordae, when the jet is anteroposterior, or there's a lead that impinges on the leaflet, then, or when the imaging quality is bad, then obviously this patient has an unfavorable anatomy. For orthopic valve implantation, valve anatomy itself is typically less important, and it can be used, for instance, in patients with severe thickening or shortening. There, it's mainly about dimensions. First of all, annular dimensions. If the annulus is too large, then the valve will not fit, it will not anchor. Other dimensions that are important, for instance, is the depth of the RV and the size of the RA, because obviously we need to be able to bring the device into the right heart and into the RV. So if these dimensions are too small, if the RV is too shallow, then the delivery is not feasible. And then finally, for the heterotopic valve implantations, this is obviously not determined by tricuspid valve anatomy itself, but it's mainly determined by caval anatomy, and also by patient factors, because these procedures are typically used for patients who have advanced disease, and there obviously the line between futility and therapeutic benefit becomes much less clear. So if we then summarize device selection in a flow chart, so if based on the mechanism, so for primary TR, if there's a prolapse and flail, if the gap is not too large, then I would say TR is probably the first line to go. When there's severe restriction or perforation of the leaflet, or leaflet quality is insufficient, then valve replacement will be your best option. For functional, it's mainly the gap size, which will determine if it's less than 8.5, and when the jet is commissural and there's only mild to moderate tethering, then TEER can be attempted. If the gap is large, or whenever there's moderate or severe tethering of the leaflet, then valve replacement would be a better option. Obviously, when the patients present really late, or the disease is advanced, and when there's severe RV dysfunction, then valve replacement is not feasible anymore, because orthopic valve implantation is not feasible because of the risk of afterload mismatch and RV failure. And there you can either opt for conservative palliative treatment or an heterotopic TTVR if that anatomy is suitable. And then finally, for the lead-related TR, that is really important, first of all, to determine whether the lead is implicated in the mechanism. If that is the case, then repositioning or removal of the lead, and for instance, implantation of a leadless device or a coronary sinus lead can be attempted. However, it's not always feasible or safe to remove a lead, and whenever that is the case, when it's deemed not feasible, or when it's unsafe, or when it's been unsuccessful, or when the lead has been successfully removed but the TR persists, then obviously additional steps are needed, and then I would say valve replacement, orthotopic valve replacement, would be the best way forward. So with that, I've come to my final slide. In conclusion, I would just like to say that whenever assessing TR, look at tricuspid valve morphology and TR mechanism. Know your landmarks. Use them to orient yourself around the valve. Use multiple views to interrogate the tricuspid valve. Try to determine regurgitation mechanism. because this is the cornerstone for both device selection, but also implantation of device and during the procedure, and also procedural success in the long term. And then with respect to TR severity, multiparametric evaluation is definitely necessary. Quantitative analysis, if possible, but be aware of the pitfalls. So integrate multiple parameters to make your final determination. I would use the 5-tier grading scheme for TRR severity, but be aware that this has not been really validated strongly. So keep an eye on the literature. Maybe these boundaries that have been set now for severe, massive T and torrential might change in the future based on more data that will become available. And then finally, don't forget to evaluate your RV function, as this will ultimately drive prognosis of our patients with TR. Thank you.